We have three other talks. I invite Professor Saravanan Margabandhu. He's a faculty of National and International CRRT Conference from India, a member of Medical Council, Indian Society of Nephrology, and also member of International Society of Nephrology, Indian Society of Organ Transplantation, Association of Physicians in India, IMA, and also member of Indian Society of Organ Transplantation, ISOT. The title is Hemoperfusion-Defender from Emergency Poisoning. Please.
I'm from Chennai, India. So I'm working in a tertiary care hospital. It's one of the biggest hospital in India, and it's the largest chain of hospitals. And we have a wide experience in treating extracorporeal therapies for liver failure and sepsis, and post-cardiac and post-liver transplant. And also, we have a limited experience, in applying extracorporeal therapies in poisoning. I thank Jaffron for giving me the opportunity to present our limited experience in those poisons. And these are the thing I'm going to discuss today. And so we need to know the background of poisoning, especially in the developing countries like in India and China. You can see the estimated incidence of suicides because of pesticide poisoning, and you can see it's highly seen in the Western Pacific region. And poisoning, it could be intentional and in unintentional also. In unintentional, accidental, basically in India as a developing country, we see a lot of poison secondary to snake bite. Snake bite envenomation is very common in India, and not only in India, in Indonesia and Philippines, we see a lot of snake bite poisons. And intentionally, the most common reason for the poisoning is pesticides, because in developing country like in India, pesticides are not banned, whereas in Western and US countries, pesticides are banned for usage. And this is important data from the from BMJ. It's an unintentional pesticide poisoning. You can see nearly annually 11,000 mortalities is happening unintentionally because of pesticides exposure among the farmers. So in this Southern Asia, India, Pakistan, Bhutan, Sri Lanka, they all number one, because of almost nearly 44% of farmers are poisoned by pesticides every year unintentionally. And they show the importance of pesticide poisoning in India. And this is an article published in India. So where we see majority reasons for the poisoning was pesticides, followed by snake envenomation and other drugs and corrosive poisons. So the disease burden from this pesticide poisoning is one of the most commonest, and you can see the curve, it is most commonly seen in Asia, China, in Asian continents compared to Western continents. So it's pesticide poisoning accounts for as many as 1 in every 5 of the world's suicides. So just show the importance of this poisoning. And between 110,000 to 168,000 pesticide cell poisoning suicides were happening every year worldwide. So over 95% of these deaths have occurred in low and middle income countries like in India and China. Actually, that's cell poisoning deaths are very much lower in higher income countries, because these hazardous materials are banned in usage. And most common cause for the pesticide poisoning is come from the paraquat and from the rat killer and from OPC poisoning. So the important thing that we should know about this pesticide poisoning, because there is no antidote available for these poisons. So we should start treatment very early to save the patients. The treatment predominantly depends on the endogenous clearance in your liver and kidney should metabolize and excrete the poison. In case if it's not going to excrete, the excreting capacity of the liver and kidney is not so very high compared to the amount of consumption of the poison, that time we need to depend on exogenous clearance, that is blood purification therapy is mandatory. If you don't treat the patient, like no patients going to get a multi-organ failure, and ultimately mortality is going to be the thing. So what are the principles and benefits of hemoperfusion that I would recommend all the readers to go through some wonderful article published by Dr. Ranko. It's a beautiful article. It's published in last year. So coming to the treatment principle, so whenever you see a poison patient, you need just get rapidly out of the poisoning environment and remove the non-absorbed poisons. So a timely deal with life-threatening situation is very, very essential, and you need to promote the removal of poisons that is already absorbed from the blood. So we need to apply an appropriate antidote if it is available, but most of our pesticide poisoning is available in our part, there is no specific antidote. So we need to rely on extracorporeal therapy or hemoabsorption to remove that poison. And once the poison, as patient is consumed, we need to give a symptomatic treatment, and we need to manage the complications. And also, we provide organ support also by CRRT and other modes of therapies. So the factors affecting the prognosis is because of the toxicity of poison and the dosage of poison, how much is consumed. And the treatment time, when are you going to start the treatment? If you delay the treatment, you're not going to save the patient. So the early the treatment, you can be able to save the patient. Not only from the treatment side, it also depends on the individuality of the patient. So it depends on how the drug gets metabolized, how it gets transported, how it's going to excrete. That also you should be aware of before starting treatment. And these are the various blood purification therapies that are available. And today's point of interest is hemoperfusion. So before applying extracorporeal therapy in poisoning patients, we should aware about the pharmacokinetics and pharmacodynamics of the poison. So what is general recommendation is, this molecular weight of the toxin is very low, and if it is highly water soluble, and if it is very less protein bound, use hemodialysis. Whereas the toxin or the poison having a very large molecular weight with less water soluble and highly lipid soluble with extensive protein bound, you apply hemoperfusion or hemoadsorption. So these are the various toxins that can be removed either by hemodialysis or hemoperfusion. So application of hemoperfusion in poisoning. So thanks to Muriet from 1948 and moving towards 1971, where the availability of Adzaba was there in the usage. But initially we were using Adzaba 7-8 years before in our hospital, and we faced a lot of complication because of that Adzaba. Adzaba is basically a charcoal-based hemoabsorber. So it can be able to remove only a small and middle molecule toxins only, and moreover most of all of the patients developed thrombocytopenia and leukopenia, and many had a charcoal embolization also. So we moved to resin-based hemoabsorption thanks to Jaffron, and based on the availability of HA230, we started using last 3-4 years. So this resin-based, what the advantage of resin-based filters over the charcoal-based filters? It has very high mechanical strength. It has large adsorptive surface area, and biocompatibility is very good, and it has adjustable pore size, and it has a peculiar design in optimized hemodynamics with advanced coating technology, and we can do a garment sterilization also. It is a highly biocompatible filter. So these are the various hemoabsorption filter available in Indian market, and we use HA230 for poisoning purpose, intoxication purpose. And these are the basic principle, already been discussing since morning. So hemoperfusion is hemoabsorption is useful whenever the toxin is having an high molecular weight and large molecular weight, high lipid solubility, high protein bound. So you apply hemoperfusion in removing those toxins. And the advantage of this hemoabsorption, there is no need for any RO water, and no need of any dialysate flow, and no need of any hydraulic pump. It just works by the principle of adsorption. And many of our poison patients have a multi-organ injury. So we need to plug and play therapy. We always combine the hemoperfusion along with either hemodialysis or with CRRT in most of the poison patients that we have faced. And this is the hemoabsorption technique that we learning from since morning. I'm just skipping this one. And these are the indication for the HA230, starting from the wide range of indications from pesticide to rodenticide to biotoxins to drug overtage and industrial toxins. There is a widespread usage. And this I already mentioned in my previous trial. What are the benefits of resin-coated hemoperfusion compared to charcoal-based? Resin having an highly advantage and highly biocompatible, and there's no risk of any embolization, and there is no risk of any thrombocytopenia or leukopenia. So coming to the paraquat poisoning, we have a limited experience and like to share with you. And paraquat is it's an 100% fatal poison because there is no antidote available, and it's very commonly available in India. I can share some of our young patients, they got the paraquat from the online shopping website. So such easily available in India. Just imagine the burden of this poison, because the patient consumes 25 to 30 ml, he is going to die for sure because there is no antidote available for this. Generally death occurs because of respiratory distress and multi-organ dysfunction. So this is the kind of one of landmark trial from China. From that, where we created our own protocol, and we also modified a sepsis protocol from Ranco also. We created our own protocol for the paraquat poisoning in our hospital in India. So whenever the patient lands in emergency, we do a routine poison thing gastric lavage, and after that we check urine sodium dithionate test. Basically we collect the urine of the patient and we see the color change actually. So and that I will explain in the next slide. So once we know that the patient has consumed the poisoning and depends on the color change of the urine, we start immediately hemoperfusion with HA230 filter. So the local generally the company people advise to use for 4 hours of an hemoabsorption, but we use 6 to 8 hours because local protocols may vary. And generally we provide 3 to 4 sessions of hemoperfusion along with hemodialysis if there is a renal involvement. Generally in the first day we provide 2 hemoperfusion, and third and fourth we do in the subsequent days. And we always give steroid and cyclophosphamide because this paraquat can cause chemical mediated, inflammatory mediated damage to the lungs and livers and kidney. So to prevent the inflammation, we always provide steroid and cyclophosphamide along with hemoperfusion and hemodialysis. And this is the routine protocol what we do. And along with this therapy, the regular CCU care monitoring daily liver and lung and renal functions, and appropriate steps we will take. And if the patient is not getting better in the 3rd or 4th day, we'll put the patient on ECMO and we work up for a lung transplant. And this is the protocol. But this protocol, we have treated almost 26 patients for the last 4 years. And being we are a referral center, we get a lot of patients across the states from India. And from this treatment, we brought down the mortality of 100% with no antidote to 56% mortality. So nearly 12 patients we could be able to save. And in the 12 patients, 1 patient was on ECMO and successfully underwent lung transplantation. And among the patients who expired, 2 were on ECMO, but unfortunately they expired. And this is the data from our hospital, it's so far unpublished, we're going to publish soon. And a dose of consumption of paraquat poisoning, it ranges from 10 to 100 ml. And median type of hemoperfusion initiation is almost 14.5 hours because we are a referral center. We always get patient in the later stage only. And almost all received the same protocol. Almost all patients received 4 hemoperfusion. In this, 3 patients received 6 hemoperfusions because the amount of toxin consumption was very high. And mortality, what we observed is more in large dose consumption. So if it is for more than 40 ml of consumption of this poison, we could not able to save with our whatever treatment what we did. And delayed initiation was also one of the important risk factor for the mortality. So as early as initiation, if you initiate very early, like within 6 to 8 hours of poison consumption, you can be able to save the patient. And 3 patients were on ECMO in the 24 patients, and 1 successfully underwent transplant, and 2 unfortunately died. And all of our patients had a liver, renal, lung, and mucosal manifestations. All these patients underwent a hybrid mode of therapy because they had a renal failure also. They underwent both the hemoperfusion, hemoadsorption with HA230 and hemodialysis. And in 3 patients, we faced prolonged renal dysfunction. Those patients, they required steroid for a long time. And no residual lung fibrosis on alive patients. So this is the urine sodium diethionate test. We actually, with the help of Jeffron, we created our own protocol, how to check the quantity of paraquat consumption. So you can see the dark blue color. It means that the patient has consumed more poison. And our, we monitor, on the day of admission and after hemoperfusion and hemodialysis, and we'll see the color change, and we can be able to say how much the poison was removed from the patient with the help of this hemoadsorption therapy. And we can place in this thing and we can see it's classically the color changes and means from the dark blue to the light blue. It means that the poison is removed from the body, but the next day you can see the rebound because it's of solute redistribution. The poison gets rebound, and we apply the second session of hemoperfusion. So by this, we can be able to brought down the mortality from 100% to 54%. And in India, the other common poisoning is rat killer poisoning. It's also very commonly available in any markets. So our liver failure, our protocol is very simple. It's usual protocol for any liver failure. We provide CRRT and plasma exchange for liver support, and we'll list them on liver transplantation. So if the patient is getting better with the CRRT and plasma exchange itself, we'll leave them. And if it's not getting better, we'll proceed with liver transplantation, and we have done many transplantation in our center and also across many centers in India. And in 2 of our patients, we have tried HA330 also along with the CRRT and plasma exchange. It's not like a DP mass, just we have tried in this patient with acute liver failure because of rat killer poison. So this patient revived. And another important poison, that is an unintentional poison because of snake inflammation, is very common in India, Indonesia, and Philippines, Malaysia, this area. Because of an agricultural activity, the snake bites are very common in this area. So the main role of snake envenomation is anti-snake venom. So beyond anti-snake venom, the patient is not getting better. That time we'll apply the extracorporeal therapy like CRRT, plasma exchange, and hemoperfusion in our patients. So it's basically it's an adjuvant therapy. It arrests the excessive cytokine release that is triggered by the dam because of this snake bite. So the early use of this therapy along with snake envenomation, anti-snake venom, to stabilize it helps in stabilizing hemodynamics, and it reduces the vasopressor dependency, and it restores the organ function and overall hemostasis. And we have used plasma exchange in our center for snakebite-induced thrombotic microangiopathy, and we have published in Asian Journal of Transfusion Medicines. And also, we have used hemoperfusion HA230 also in one of our patients. We had a severe DIC even after 40 vials of anti-snake venom. He was not improving, and we have treated him with hemoperfusion 2 sessions, and he has recovered well. And this is one more important center in southern part of India. It's a rural India where we see a lot of snake envenomation. This is a critical care center. There are a lot of unpublished work by Professor, my senior colleague, Professor N. Ganapathy. He has treated almost more than 50 patients actually with snake envenomation with hemoadsorption and successfully revived their life. And coming to the drug overdosage and drug poisoning, and we know Michael Jackson was an homicide as a result of combined drug intoxication. Interestingly, we treated a medical student, 21 years old, and she was depressed in hostel, and she was brought to an emergency in the state of shock, liver dysfunction, and encephalopathy with an acute kidney injury. and we were sure like no, she had consumed some unknown poisoning. So like no, for the life-saving thing, like no, we put her on ECMO, and we sent a toxic screening analysis also. So we couldn't able to wait for the thing because she was crashing down on ECMO. So we put her on hemoperfusion, and totally like no, 3 sessions of hemoperfusion with HA230 we have done along with CRRT. Ultimately, the patient recovered. Like no, once the patient like no came out of the ventilator and ECMO support, like we inquired like no, she has took almost like no 55 tablets of paracetamol and 40 tablets of nifedipine and 40 tablets of pregabalin. So like no, so in that way, hemoperfusion was very helpful in treating some unknown poisoning. We were not sure like no, because otherwise she is a medical student. We were about to lose her on the ECMO. So we have done hemoperfusion along with an ECMO, and we saved her. And this is a famous fiction novel that a British writer, Agatha Christie, we know that when like no, some kind of an unknown murder happening, and ultimately it found to be a thallium poisoning, because it's a poisonous poison. So since it is very colorless, odorless, tasteless, it was used as an homicide. And we have actually like no, we treated like a couple of months before, we have encountered a 45 years old industrial worker with alleged consumption of thallium. And we have done 3 sessions of hemodialysis and HA230 sessions, and the patient is improved ultimately. And this is the other study from India, from our colleague Dr. Deven Juneja. So where the suicidal intake of digoxin poison was there, like in that particular situation, that Fab fragment of anti-digoxin antibody was not available. So we have done an hemoperfusion and saved this patient. And the next speaker is going to speak about Arunophosphorus, and I'm skipping this one. And so I would like to like include the poster presentation there, like from the Ecuador and from Turkey, like where the HA230 filter was used for poisoning like verapamil and calcium channel blockers and valproates. And it's also useful in poisonings like carbamazepine and methotrexate. There are a lot of literature evidence for that, and we didn't have an experience in those poisons. And there are other evidence for using this adsorption in wasp stings and aberrant poisonings also available. And to sum up, so hemoadsorption, it helps in accelerating poison elimination. It reduces metabolic substances. It alleviates the complications and keep the internal environmental stable. It not only reduces the hospitalization stay, it also improves the survival. So the recommendation, you need to use the hemoperfusion as early as possible, and more frequent hemoperfusion treatment should be given at the beginning stage itself. That is what we recommend. Thank you.
Thank you, Dr. Margabandhu. Thank you very much for that interesting talk.